Hello and welcome. Today we're going to be undertaking a really comprehensive examination of a subject.
A subject that's everywhere.
Exactly. It permeates modern life, but it's still so frequently misunderstood. I'm talking, of course, about anxiety disorders.
Right.
And I've got in front of me just a substantial amount of material.
Hmm.
Medical literature, clinical data, psychiatric studies.
It's a topic that really requires precision.
It does. Our goal here is to move past the casual use of words like stress or being nervous.
Which get used interchangeably.
All the time. So we want to engage in a really rigorous, factual exploration. We're going to try and build what is essentially a biography of the condition.
The biography. I like that framing.
Yeah. We want to trace the life of anxiety itself from its evolutionary roots in our most ancient ancestors.
All the way through its development in a person's life.
And right up to how it manifests across the globe right now.
And to do that properly, as you said, we need precision. We're not just discussing feelings that come and go. We are looking at incredibly complex physiological, cognitive, and biological systems that have a very specific history.
And a specific function, even if it doesn't feel like it.
Especially if it doesn't feel like it.
Okay, so to start that biography, we absolutely have to define our terms. Because in everyday conversation, people use fear and anxiety as if they're the same word.
They're treated as synonyms, yes.
You'll hear someone say they're anxious about a public speech or fearful of, a spider. The line is blurry in just, normal talk.
It is, but when you look at the clinical texts, the distinction is it's a very hard line.
They are not the same thing at all.
Not at all. From a clinical perspective, they are two very distinct phenomena. They have different triggers, different physiological profiles.
So let's draw that line. What is fear, clinically speaking?
Fear is defined as an emotional and physiological response to a recognized immediate external threat.
Immediate and external.
The key words. It's a reaction to something that is present, happening right now. You see a real danger, a car swerving towards you, and your body reacts.
So fear is the hardware response. It's the there's a tiger in the room right now feeling.
Precisely. It's present focused. It's about an identifiable source of danger.
Okay, then what is anxiety?
Anxiety, by contrast, is an unpleasant emotional state where the cause is. It's often not readily identified, or, if it is, it's perceived as uncontrollable or unavoidable.
That's a little more vague.
It's much more cognitive. The literature defines it as a disorder involving excessive irrational dread of everyday situations. It's the anticipation of a future threat.
So it's not a reaction to what's happening, but a prediction of what might happen.
Yes, that is the critical distinction.
So to go back to my analogy, fear is the tiger is in the room. Anxiety is, I have this creeping feeling a tiger might get into the room or could be in the room later, and what would I do? And I don't think I'd be able to stop it.
Exactly. It's the shadow of the threat, not the object itself. It is the brain projecting into the future and running simulations of negative outcomes that haven't happened.
And may never happen.
And very often will never happen.
And the scale of this, when you look at the numbers, it's just immense.
It's staggering.
Looking at the epidemiology, anxiety disorders are the most prevalent psychiatric condition in the United States. The only thing more common is substance use disorders.
So this is not a niche issue affecting a small number of people.
Not at all. And if we zoom out and look at the global data, the most recent complete data set here is from 2010. Approximately 273 million people were affected.
Which was about 4.5% of the entire global population at the time.
4.5%.
Yeah.
And even within that huge number, there are specific patterns.
Yes, the demographic distribution is not even. There is a very notable gender disparity in the prevalence rates.
It's more common in women.
Significantly more common, yes. The data shows the condition affects about 5.2% of females compared to 2.8% of males.
So almost double.
Nearly double, yes.
Which brings us back to that biography idea. We have to ask the fundamental question. How did we even get here? Why does our own biology contain a mechanism that is capable of causing so much distress on such a massive scale?
It's the central question of evolutionary psychiatry.
Right. If evolution is all about survival of the fittest, why would it select for a trait that can be, completely debilitating for some people?
To answer that, you have to reframe the question. You have to interpret anxiety not as a flaw initially, but as a vital part of an evolved defensive system.
It's a feature, not a bug.
At its core, yes. It's a mechanism that has been calibrated over millions of years to detect potential threats. In literature, this concept is often called the smoke alarm principle.
Okay, let's spend a minute on this because this concept is, I think, fundamental to understanding everything else. The smoke alarm principle.
Think about the smoke alarm in your house. Its primary job is to alert you to a life-threatening fire.
Right, it screams at you, you get out, it saves your life.
But it will also go off if you, say, burn a piece of toast in the kitchen.
Or take a really hot shower and the steam gets into the hallway.
Exactly. That's the essential trade-off. From an evolutionary standpoint, our anxiety mechanisms are designed to be just like that smoke alarm. They are built to err on the side of false alarms.
Better safe than sorry, on a biological level.
It's a simple cost-benefit analysis. The logic is purely mathematical. The cost of a false alarm, feeling distressed, getting a shot of adrenaline, running away from a shadow, is relatively low.
You burn some calories, you feel a bit foolish, but that's it.
That's it. You lose a little energy, but the cost of a miss, of failing to detect a real predator because your system was too relaxed,
The cost is infinite.
it's death. You're removed from the gene pool.
So let's picture in an ancestral environment. You have two of our early ancestors. They're out on the savannah. They both hear a rustle in the tall grass.
Okay.
Ancestor number one immediately assumes it's a lion. He has a full-blown panic response and runs for the nearest tree. It turns out it was just the wind.
So a false alarm.
A false alarm. He feels a bit silly. He's wasted some energy, but he's alive. Now, ancestor number two hears the same rustle and thinks, it's probably just the wind. He stays put.
And if it is a lion?
He's gone. His genes are gone.
Correct. Therefore, natural selection favored the system that is, for lack of a better term, trigger-happy.
We are the descendants of the anxious ones.
We are the descendants of the ancestors who survived because they reacted to the false alarms. We simply did not descend from the ones who were too relaxed to notice the very real dangers around them.
So our biology is fundamentally calibrated to be a little paranoid. But this brings up a huge problem when you apply that ancient hardware to our modern world.
And that leads directly to what the research calls the mismatch theory.
The mismatch theory. Explain that.
The mismatch theory posits that there's a fundamental disconnect, a mismatch, between the environment our threat detection systems evolved in and the one we currently inhabit.
Our bodies and brains are built for the savannah, but we live in cities.
In essence, yes. Our systems were built for immediate, acute physical dangers, predators, hostile tribes, sudden environmental hazards, things that could kill you in an instant.
Things that required an immediate fight-or-flight response.
Precisely. But today, the threats we face are completely different.
An angry email from your boss. A notification from your bank. A pile of unpaid bills.
Social media arguments. These things cannot physically harm you, not in the way a lion can, but they trigger the very same ancient hardware.
The smoke alarm doesn't know the difference between a predator and a performance review.
It doesn't. And crucially, contemporary threats are often chronic, not acute. A predator attacks and then the event is over. It leaves.
Right. The threat is resolved, one way or another.
Financial stress doesn't leave. Job insecurity doesn't just go away. So when that ancient, exquisitely sensitive smoke alarm is constantly being triggered by modern, low-level but persistent stressors,
You get chronic anxiety.
you get chronic or generalized anxiety. The system is working exactly as it was designed to. It's just operating in a completely alien environment it was never built for.
That context is so important. It shifts the entire perspective from my brain is broken to my brain is actually over-functioning for this environment.
It's a system in overdrive.
Okay, so with that evolutionary origin established, we need to move into the classification.
Yeah.
Because anxiety isn't a monolith.
No, it has many different expressions.
The medical literature groups them under the term anxiety disorders, but they manifest very, very differently. I think we should start with the broadest form, generalized anxiety disorder.
GAD.
Yes, GAD is characterized, as its name suggests, by long-lasting anxiety that isn't focused on any single specific object or situation.
It's just there all the time.
It's a non-specific, persistent state of fear and worry.
And we need to be very precise about that word worry, because everybody worries.
You worry if you're going to be late for a meeting or if you left the oven on. But GAD is a clinically different thing. The literature here defines it as chronic excessive worry.
And the diagnostic criteria are very specific. The duration and the intensity are what matter. To receive a GAD diagnosis, an individual must be excessively worried about everyday problems for 6 months or more.
6 months. So this isn't a bad week.
This is a prolonged state of being. And it isn't just a mental state, a preoccupation. It has to be accompanied by a specific set of physical and cognitive symptoms.
What are those?
Things like restlessness, feeling keyed up or on edge, being easily fatigued, difficulty concentrating or your mind going blank, irritability, muscle tension, and very commonly, sleep disturbance.
It's that word excessive that seems to be the key metric. The worry is out of proportion to the actual likelihood or impact of the feared event.
Yes, and it permeates everything. It affects family life, social interactions, work performance. It becomes a constant background noise.
And it takes a physical toll. We're not just talking about someone, furrowing their brow. The literature describes some very clear physical signs.
A person with GAD often presents with a strained appearance. There's often increased sweating, specifically noted in the hands, feet, and under the arms, the axillae.
And even tearfulness.
Yes, and it significantly affects day-to-day functionality. People with GAD often find they have trouble making simple daily decisions or remembering commitments.
Why is that?
Because their concentration, their cognitive bandwidth, is entirely consumed by the cycle of worry. It's like trying to listen to a conversation with loud static playing in your ears all the time. It drowns out the present.
There's also a demographic note here. GAD is the most common anxiety disorder affecting older adults.
That's correct. While it can begin at any age, it is particularly prevalent in later life.
Okay, so that's the general. Now let's move to the specific. The largest single category of anxiety disorders is, appropriately, specific phobias.
Specific phobias are highly prevalent. They affect somewhere between 5 and 12% of the population globally.
And the definition is pretty straightforward.
It is. It's an intense, persistent fear of or an aversion to a specific object or situation.
We're talking about the things people commonly think of. Fear of flying, fear of heights, spiders, injections, blood.
Water, enclosed spaces like tunnels or elevators, highway driving. The list is long.
But again, like with worry, we have to distinguish between a dislike and a clinical phobia. I don't like spiders, but I don't think I have a phobia.
The clinical distinction lies in the intensity of the reaction and the level of impairment it causes. The fear response is grossly disproportionate to the actual danger posed by the object.
So what does that reaction look like?
When exposed to the phobic stimulus, an individual might experience trembling, shortness of breath, a rapid heartbeat, and overwhelming desire to flee. They anticipate catastrophic consequences from the encounter.
And one of the most interesting diagnostic features mentioned in these texts is the person's own insight into their fear.
Yes, this is key. People with specific phobias almost always understand that their fear is irrational and excessive.
They know it doesn't make sense.
Exactly. An adult who has a severe phobia of a harmless garden spider knows on an intellectual level that the spider cannot hurt them. They can tell you it's a ridiculous fear.
But they can't stop the reaction.
They are still completely overwhelmed by the physiological fear response,
Right.
and they will go to extreme lengths to avoid that trigger, which in turn reinforces the phobia.
That awareness, that self-awareness that the fear is illogical, but being powerless to stop the physical cascade, that seems to be a real hallmark of the pathology.
It is. It's a profound and distressing disconnect between the rational mind and the emotional, physiological response.
All right, let's now discuss a form of anxiety that is, for the person experiencing it, perhaps the most physically intense and terrifying. Panic disorder.
Panic disorder is distinct from GAD because of the acute nature of the episodes. GAD is a slow, chronic burn. Panic disorder is a sudden, violent fire.
It's defined by these brief attacks of intense terror.
Intense terror and apprehension, yes. These attacks have a very specific profile. An abrupt onset of fear or discomfort that peaks in intensity in less than 10 minutes.
The peak is that fast.
Incredibly fast. Though the peak is rapid, the lingering effects of the attack, the exhaustion and shakiness, can last for several hours.
And the triggers. This is what makes it so insidious.
They can be anything. Stress, irrational thoughts, even physical exertion. But what makes panic disorder so difficult is that sometimes there is no trigger at all.
It can happen out of the blue.
Completely without warning. A person could be watching television or just walking down the street and be hit by this overwhelming wave of terror.
But the disorder isn't just about having an attack. I mean, the data suggests a lot of people might have one panic attack in their life during a period of extreme stress.
That's a critical point. The diagnosis of panic disorder isn't given for a single attack. The disorder is defined by the destructive feedback loop that follows an attack.
The fear of fear.
We call it exactly that, the fear of fear. A diagnosis of panic disorder requires that the attacks have chronic consequences. The person begins to worry incessantly about having more attacks.
And they change their behavior.
They make significant behavioral changes specifically to avoid situations they believe might trigger another one.
This leads to that state of, what's the term? Hypervigilance.
Yes. The person becomes hypervigilant, obsessed with monitoring their own body's functions. They're constantly checking their heartbeat, their breathing, their digestion.
So a completely normal change in heart rate, say, from walking up a flight of stairs,
Is immediately misinterpreted by the brain as the beginning of a heart attack. A moment of slight dizziness is interpreted as a brain aneurysm or a stroke.
so they're mistaking the body's normal operations for a catastrophe.
Exactly. The brain misinterprets these normal, benign physiological signals as signs of a catastrophic medical event. This, of course, creates more fear, which releases more adrenaline, which creates more physical symptoms, and the cycle perpetuates itself.
A truly vicious cycle. Now, often linked directly to panic disorder is agoraphobia.
Very often, yes.
And this is a term that gets misused a lot in popular culture. There's this common idea that agoraphobia is just a fear of open spaces or a fear of leaving the house.
That's a common oversimplification. The clinical picture is much more specific and nuanced.
So what is it technically?
Agoraphobia is the fear of being in a place or a situation where escape might be difficult or embarrassing. Or critically, where help might not be available in the event that they have a panic attack.
So it's not about being outside, it's about being trapped.
It is fundamentally a fear of being trapped with the symptoms of panic. The connection to panic disorder is very strong. The individual feels having a panic attack in a public place, a crowded theater, a bus, a bridge, a long checkout line, and being unable to get away or get help.
So you see behaviors like what?
You might see someone who always needs to sit near an exit, a person who always needs to be in view of a door. They need a clear escape route at all times.
And the literature also mentions needing a safe person.
Yes, needing a trusted companion with them to venture into feared situations. In the most severe cases, this pattern of avoidance behavior spirals until the person effectively becomes housebound.
But not because they're afraid of the fresh air.
No, it's because their home is the only environment they feel they can control, the only place where they feel safe from the terrifying prospect of having a panic attack and not being able to escape.
And every time they avoid a situation and feel relief, it just reinforces the fear.
It teaches the brain a powerful lesson. Avoidance equals safety, and that makes the world feel smaller and smaller.
Let's shift from physical spaces to the social realm. Social anxiety disorder, or SAD.
Yes.
This is another one that's often dismissed as just being really shy, but the clinical reality is far more severe.
Social anxiety disorder is defined as an intense fear and avoidance of negative public scrutiny, humiliation, or social interaction. It's a major issue, affecting roughly 7% of American adults in any given year.
So this isn't just feeling a bit awkward at a party you don't want to be at.
No. For someone with SAD, a social situation can trigger an intense physiological response. We're talking about visible blushing, profuse sweating, a racing heart, trembling, and difficulty speaking.
It's an intense physical rejection of being observed by other people.
Yes. The core fear is being judged negatively. And there's a specific subtype mentioned in the literature here that's worth noting.
Social physique anxiety.
Social physique anxiety, or SPA. This involves a very specific concern over the evaluation of one's body by others.
So it's not about what you say, it's about how you look.
Precisely. It's the anxiety derived specifically from the prospect of being physically judged. While the data shows it's particularly common among adolescents and females, it can affect anyone.
And then there's one of the lesser known but highly specific disorders, selective mutism.
Right.
The name is descriptive, but it's often misunderstood as a deliberate choice.
That's the key misconception. Selective mutism is a disorder where a person who is normally capable of speech does not speak in specific situations or to specific people. It almost always coexists with extreme shyness or social anxiety.
And it's important to clarify, this is not a refusal to speak. It's not a child being stubborn.
Absolutely not. It is not a behavioral refusal in that sense. The individual remains silent even when the consequences of that silence are severe shame, social ostracism, even punishment at school.
They can't speak.
They are physically unable to overcome the inhibition to speak in that specific context. It's a freezing response, not a defiant choice.
Okay, we've covered the major classifications of these disorders in adults.
Right.
Now we have to look at the developmental timeline. This isn't just an adult problem.
Far from it. The epidemiology in youth is striking. The data suggests that between 10 and 20% of all children will develop a full-fledged anxiety disorder before they turn 18.
10 to 20%.
It is the single most common mental health issue affecting young people.
But the way it presents in children is often very different from how it looks in adults.
It is, and this creates significant challenges for identification and diagnosis.
How so?
Children, especially young children, often lack the emotional vocabulary to articulate complex feelings like dread or worry or a sense of impending doom. They don't have the words for it.
So how does it come out?
They interpret and express their emotions physically. Anxiety disorders in children frequently manifest as physical complaints: stomach aches, headaches, nausea, heart palpitations.
So a child who consistently has a stomach ache every morning before school, it might not be a virus.
It might not be. They may be suffering from generalized anxiety disorder.
And when does GE typically show up in kids?
The typical age of onset for GE in children is around 8 to 9 years old.
And because of these physical complaints, or maybe acting out behaviorally because they feel so uncomfortable?
It's often misdiagnosed. It can be mistaken for ADHD because the child is restless and can't focus, or it's treated purely as a series of physical ailments without addressing the underlying anxiety.
There's also a disorder specific to this developmental stage. Separation anxiety disorder, or SEPAD.
Yes.
Now, to be clear, some separation anxiety is a completely normal part of development for a baby or a toddler.
Yes. In infants, it's an expected and healthy behavior. It's a sign of a secure attachment to a caregiver.
So when does it become a disorder?
It becomes SEPAD when the anxiety over being separated from a person or a place is excessive and inappropriate for the individual's developmental level.
And it can be quite severe.
The literature notes that childhood cases of SEPAD tend to be more severe than cases that develop in adulthood.
And there's a complicating factor here involving the parents.
Parents play a very significant role, often unintentionally.
Oh, so?
A parent may unintentionally reinforce the anxiety because they don't know how to work through it with the child. If a child becomes hysterical about being dropped off at school and the parent immediately gives in and takes them home to soothe them,
They're teaching them that avoidance works.
they're reinforcing the idea. The child's brain learns two things. First, that their fear was valid because even my parent reacted to it. And second, that avoidance is the solution to that fear.
We also have data on specific risk factors in youth. What makes one child more susceptible than another?
It's a combination of genetics and environment. Trauma and abuse are, unsurprisingly, very significant predictors.
A child who has a history of abuse or neglect and has low self-esteem
Is much more prone to developing GAD and panic disorder later in life. Their early environment has essentially taught them that the world is an unsafe, unpredictable place.
But there are also some risk factors that seem almost counterintuitive. For instance, the literature mentions giftedness.
Yes, studies have suggested that gifted children can be more prone to excessive anxiety than their non-gifted peers.
Why would that be?
The theory is that their heightened cognitive capacity allows them to imagine future scenarios in much greater detail and with more complexity. They can essentially outthink their own sense of security.
They can visualize all the things that could possibly go wrong.
In vivid detail, they can construct intricate scenarios of failure or threat that other children might not even consider.
And another one mentioned is hypercompetitiveness.
A 2011 study specifically linked high hypercompetitive traits to an increased risk of anxiety. The intense, relentless drive to win or be the best can fuel a constant fear of failure, which is a core component of anxiety.
So it highlights how anxiety can get tangled up with traits we might otherwise see as positive, like being very intelligent or ambitious.
Exactly. Those traits become maladaptive when they spiral into excessive worry and a paralyzing fear of not measuring up.
Okay. We've defined the disorders, we've classified them, we've looked at who they affect and when. Now we have to turn to the incredibly difficult problem of diagnosis.
And it is difficult.
It's not like diagnosing a broken leg where you can take an x-ray or an infection where you can run a blood test.
It is fundamentally a diagnosis of exclusion. There are, as of now, no objective biomarkers or laboratory tests. No blood test, no brain scan that can definitively say, this person has panic disorder.
So diagnosis relies on symptoms, patient history, observation.
all of which are subjective. And this makes the process of differential diagnosis absolutely critical.
Which is the medical term for?
For ruling other things out, ruling out the imposters. Because there is a very long list of medical conditions that can look exactly like an anxiety disorder, but are actually rooted in a purely biological malfunction elsewhere in the body.
This step is crucial.
It's the first thing a responsible clinician must do. Before you treat the anxiety, you have to be sure it is anxiety and not something else masquerading as it.
Let's go through that list of medical mimics because it's extensive, and it really reveals how deeply physical the sensation of anxiety can be. It's not all in your head if the problem is, say, your thyroid.
A perfect example to start with, the endocrine system.
So things like hyperthyroidism.
Hyperthyroidism, an overactive thyroid, essentially speeds up the body's entire metabolism. It can cause a racing heart, sweating, trembling, weight loss, symptoms that are almost identical to a chronic anxiety state.
And hypothyroidism, an underactive thyroid, can also present with anxiety.
It can, as can other endocrine issues like hyperprolactinemia.
Next on the list are metabolic disorders.
Diabetes is a major one. Fluctuations in blood sugar, especially hypoglycemia or low blood sugar, trigger a massive release of adrenaline from the adrenal glands.
A full-on fight-or-flight response.
Yes, it perfectly mimics a panic attack. Shaking, sweating, heart palpitations, confusion, a feeling of doom.
Nutritional deficiencies are also on the list.
Yes. Low levels of several key vitamins have been linked to anxiety-like symptoms, specifically vitamin D, B2, B12, and folic acid, because these vitamins are essential for the proper function of the central nervous system. A deficiency can disrupt neurotransmitter production and regulation.
Then there are gastrointestinal issues.
The gut-brain axis is a major area of research. We now know there's a profound connection. Conditions like celiac disease, non-celiac gluten sensitivity, and inflammatory bowel disease can all manifest with significant psychological symptoms, including anxiety.
The inflammation in the gut is affecting the brain.
That's the theory, that systemic inflammation can cross the blood-brain barrier and create neuropsychiatric effects.
Even degenerative brain diseases can present as anxiety first.
Yes. Conditions like Parkinson's disease, dementia, multiple sclerosis, and Huntington's disease often have anxiety as an early or concurrent symptom before the more recognized motor symptoms appear.
And there's a specific immune condition mentioned here, MCAS.
Mast cell activation syndrome. It's a complex immune condition where the body's mast cells become overactive and release too many chemical mediators, like histamine.
And that can cause anxiety.
It can cause a huge range of symptoms, including profound anxiety and panic attacks, due to the inflammatory effects of those mediators on the brain and nervous system.
So beyond diseases, we have to consider substances. Substance-induced anxiety.
A major category. Many substances, both legal and illegal, can either cause or significantly worsen anxiety.
Caffeine is probably the most common one.
Absolutely. Caffeine is a powerful stimulant that can directly trigger the fight-or-flight response. For a sensitive individual, a strong cup of coffee can be enough to induce a panic attack.
And alcohol. People often use it to treat anxiety.
They do because it's a depressant. It calms the system down initially, but as the alcohol wears off, the brain experiences a rebound excitation which can cause severe anxiety and insomnia.
The so-called hangxiety.
Precisely. And the list goes on. Cannabis, sedatives, opioids, stimulants. All can induce anxiety.
And there's a particularly cruel paradox here regarding medications that are actually used to treat anxiety.
Yes. Withdrawal from certain anxiolytic drugs, most notably benzodiazepines, can cause severe rebound anxiety.
So the symptom the drug was meant to suppress comes back even stronger when you try to stop taking it.
Correct. It can create a powerful cycle of dependency where the person is afraid to stop the medication for fear of the withdrawal symptoms.
So once all these mimics are ruled out and a formal diagnosis is made, then we can move on to treatment and management.
Then we can.
The modern approach, based on this material, seems to be multimodal. It's not just one thing. Let's start with psychotherapy.
The first-line gold standard treatment recommended across almost all the literature is cognitive behavioral therapy, or CBT.
How does CBT actually work for anxiety? It's not just, lying on a couch talking about your childhood.
No, it's very structured and present-focused. CBT works by helping the patient identify, challenge, and reframe the distorted thought patterns and maladaptive behaviors that create and sustain the anxiety.
So it's about teaching the person to recognize that their smoke alarm is going off for burnt toast, not a fire.
That is a perfect way to describe it. It teaches them to recognize the false alarm and then choose a different, more rational response, rather than defaulting to the panic or avoidance behavior.
And the data on its effectiveness.
It's very strong. It's been shown to be effective whether it's delivered face-to-face with a therapist or even via structured programs over the internet.
But it's not a one-and-done cure.
No, it requires maintenance. The skills have to be practiced. Booster sessions are often recommended to prevent relapse over the long term.
What about other therapies?
Mindfulness-based programs have also shown significant efficacy. For children, particularly those who are nonverbal or have experienced trauma, things like art therapy and play therapy are very valuable.
How those help?
They allow the child to express and process their fear and trauma in a nonverbal way, in a safe and controlled environment, without the pressure of having to find the right words for their experience.
So therapy is one pillar. The other, of course, is medication.
The pharmacological options, yes.
This is a complex area. Let's start with the first-line medications.
The first-line choices for most anxiety disorders are typically the SSRI selective serotonin reuptake inhibitors and the SNRIs.
And these work on neurotransmitters in the brain.
They work to regulate neurotransmitters like serotonin and norepinephrine, which play a key role in mood and anxiety.
Is there one particular SSRI or SNRI that's considered the best?
Interestingly, for adults, there is no good evidence to suggest that any one medication in these classes is superior to another.
So how is the choice made?
Often, it comes down to factors like cost, potential side effect profiles, or a patient's previous experience with a medication. The key is not which one you start, but the duration of treatment.
How long?
If a medicine is found to be effective, it is strongly recommended that it be continued for at least a year to significantly reduce the risk of relapse after stopping.
Stopping too early is a major problem.
A very common cause of recurring symptoms, yes.
Okay, so that's the first line. Then we have second-line treatments, which include the class of drugs known as benzodiazepines.
Yes. Benzodiazepines are very effective for providing rapid, acute relief from anxiety symptoms. They work quickly to calm or sedate the nervous system.
But they're not a first-line treatment.
They are not, and for very good reasons. They come with significant risks.
What are those specific risks?
There's a high risk of developing physical and psychological dependence. There can be cognitive impairment, memory problems. In older adults, they're associated with an increased risk of falls. And most seriously, there's a risk of overdose and death, especially when they're combined with opioids or alcohol.
So their use has to be very cautious.
Very cautious, and typically for short-term use, not as a long-term management strategy.
Beyond therapy and medication, the literature points to some lifestyle interventions that can be surprisingly effective.
Lifestyle changes are a critical and often underutilized component of management.
The first one on the list here is a data point that really stands out to me: smoking cessation.
Yes.
This is so counterintuitive because you hear people say all the time, I need a cigarette to calm my nerves.
It's one of the great misconceptions about anxiety. The data is unequivocal. Stopping smoking has benefits for anxiety that are as great as, or in some cases greater than, the benefits of medication.
Why is that?
2 reasons. First, nicotine is a powerful stimulant that actually mimics and worsens anxiety symptoms. Second, the calm a smoker feels when they have a cigarette is largely just the temporary relief of their nicotine withdrawal symptoms. The smoking itself traps them in a constant cycle of craving, withdrawal, and relief that elevates their baseline level of anxiety.
So the cure is actually part of the cause.
In many ways, yes.
Diet also seems to play a role.
A meta-analysis cited in the materials found that omega-3 polyunsaturated fatty acids, what you'd find in fish oil at doses of 2,000 milligrams a day or more, tended to reduce anxiety symptoms, particularly in people with a clear clinical diagnosis.
And what about cannabis? There's a huge amount of public discussion around its use for anxiety.
Yes, but as of the 2019 update in our source material, the clinical evidence is not there. There is currently little evidence to support the use of cannabis in treating anxiety disorders.
Despite anecdotal reports.
While some individuals report short-term relief, for others, particularly with higher THC strains, it can significantly exacerbate paranoia and anxiety. The clinical evidence for it as a reliable treatment is just not sufficient at this time.
Okay, so we've looked at the biology, the psychology, the chemistry, but we have to look at the sociology. Anxiety doesn't exist in a vacuum. It exists in a society.
And that society often stigmatizes it.
Stigma is a massive barrier to people getting help.
It's a huge barrier to treatment, and it operates on multiple levels. The literature describes 3. the macro level, which is society at large, media representations,
The intermediate level.
which can include healthcare professionals themselves who might dismiss a patient's symptoms as just stress,
And then the micro level.
which is self-stigma, the shame and negative beliefs a person holds about their own condition.
And these are fueled by pervasive misconceptions. The belief that anxiety isn't a real medical illness,
Or that people should just be able to snap out of it or turn it off through willpower.
or that it's a sign of personal weakness.
All of this leads to a profound reluctance to seek help. If you believe your condition is a character flaw rather than a legitimate medical issue, you're not going to see a doctor about it. You're going to suffer in silence.
And this seems to be particularly relevant for the college-age demographic, where we're seeing a significant rise in prevalence.
Anxiety has become one of the main mental health challenges in early adulthood. The literature attributes this to a convergence of factors: immense social pressures, worries about career prospects, and unprecedented financial hardship like student loan debt.
The transition to adulthood has become a period of prolonged uncertainty.
It has, and this is having a measurable effect on the mental health and overall quality of life for this generation.
So, final question. Is prevention possible? Can we stop this before it even starts?
There is an increasing focus on prevention, yes. There's some tentative evidence for things like CBT and mindfulness programs being used as preventative measures in at-risk populations.
But for adults,
A major 2013 review found no effective measures for preventing generalized anxiety disorder in adults specifically. The most promising area for prevention seems to be in childhood.
through parent education programs.
Exactly. Educating parents on how to respond to a child's fears without accidentally reinforcing them. Teaching parents how to foster resilience and encourage bravery rather than solidifying avoidance. That shows real promise in preventing the development of full-blown disorders later in life.
So, to summarize our examination today,
Uh-huh.
we have traced anxiety all the way from a necessary, life-saving evolutionary smoke alarm designed to save our ancestors from predators.
To a modern disorder that, for millions, is characterized by excessive floating dread that disrupts daily life.
We've classified its many different phases, from the chronic worrying day to the terror of panic to the specificity of phobias.
We've seen how it can manifest physically, particularly in children, and how challenging it can be to distinguish from a whole host of other medical conditions.
But the crucial point is that while it is a significant burden affecting nearly 1 in 3 adults at some point in their lives, it is treatable.
Very treatable. Through effective therapies like CBT, appropriate medication management, and supportive lifestyle changes, the vast majority of people are able to manage their symptoms and lead normal, productive lives.
It's a condition of our biology, not just our psychology, a system that is perhaps working too well. We're just at the wrong time in history. And as we conclude, I think we should leave you with that smoke alarm concept one last time. In a world that is, by any objective measure, safer than ever before from immediate physical threats, our internal alarms are ringing louder than ever. It forces us to ask, how much of modern anxiety is simply our ancient biology working correctly in an environment it was never ever built for? Thanks for listening.
Thanks for listening.